Well, hello, everybody. My name is Victoria Chernak. I come from Montefiore Medical Center, and today I will speak to you about HCC diagnosis and application of LIRADS. I have no relevant disclosures. I do want to acknowledge that some of my ideas and schematics either come from or are inspired by LIRADS manual and at least partially created by Dr. Claude Serlin. So what we'll do today is we'll talk about the process of hepatic carcinogenesis, discuss a little bit about HCC diagnosis, and then dive into diagnosis of HCC with LIRADS. So the process of hepatic carcinogenesis starts with a cirrhotic nodule, and progressively the cirrhotic nodule can develop into low-grade dysplastic nodule, and then progress to high-grade dysplastic nodule. And in this process, as the nodule grows, you can see that the portal triad density begins to decline, and as a result, arterial flow begins to decline. The next step in hepatic carcinogenesis is development of early HCC, at which point portal venous supply decreases enough for us to detect these lesions as hypovascular masses. The next step, as the clonal expansion continues, the lesion transforms into small progress HCC, at which point the density of unpaired arteries increases, and as a result, we have increased arterial flow. As the process continues, the progress HCC can develop into large progress HCC, at which point we may form a capsule, and in the later stages, we can have transcapsular infiltration. Important thing to remember that infiltrative HCCs can switch to glycolytic metabolism, and as a result, the arterial flow in those lesions will decline. So why is HCC diagnosis so complicated? Well, first thing we have to remember is not all primary malignancies in cirrhotic patients are HCCs. If we look at the hepatic progenitor cells, they can normally differentiate into hepatocytes, which then, through oncogenic transformation, form HCC. These same hepatic progenitor cells can normally differentiate into cholangiocytes, which then can, through oncogenic transformation, develop into intrahepatic cholangiocarcinoma. And to make the matters a little bit more interesting, these same hepatic progenitor cells can give rise to hepatic cancer stem cells and then differentiate into the combined HCC cholangiocarcinomas, and on top of that, the dedifferentiation from either ICCA or HCC can occur and again lead to a combined tumor. On top of this complicated kind of process, not all lesions in cirrhosis are malignancies. We can have many cirrhosis-associated hepatocellular nodules. We can have benign non-hepatocellular lesions such as cysts and hemangiomas. We can also have non-mass lesions, including fat depositions or sparing, hemorrhage, edema, and areas of confluence of fibrosis. We can have treated lesions, and of course, we can have our primary and secondary malignancies. In addition, it's important to remember that not all observations in a patient with cirrhosis are true lesions. We can have pseudolesions, including artifacts, vascular pseudolesions, and hypertrophic pseudomasses. And this is the reason why LIRADS doesn't use the words such as mass or lesion or nodule, but rather goes for a term of observation, which is defined as distinctive area relative to the background liver, and it's a preferable term because it is applicable to both true lesions and pseudolesions. So again, why is HCC diagnosis so complicated? Well, we need to detect the tumor. We need to distinguish it from all other pseudolesions that occur in cirrhotic liver. We also need to distinguish it from benign lesions and distinguish it from other malignancies. And we need to do so with specificity close to 100%. So you can ask, why do we need near 100% specificity? Because in most other situations when we diagnose malignancy, this is not a requirement. When we look at the kind of this chart summarizing the the treatment options for various categories in LIRADS, notice that in LIRADS 5, HCC is confirmed, and the patient goes to multidisciplinary discussion for consistent management, which means that a patient is diagnosed with HCC without biopsy confirmation and can undergo things like liver transplantation. So if this is the case, we want to be absolutely certain that when we call something LIRADS 5, it is truly an HCC. So what is LIRADS? LIRADS is a system for standardized imaging for liver cancers. And we have 4 algorithms in the current LIRADS system. Ultrasound LIRADS is dealing with surveillance of HCC. Contrast-enhanced ultrasound LIRADS is used for diagnosis of HCC. CT MRI diagnostic LIRADS is used for diagnosis and staging of HCC. And CT MRI treatment response LIRADS is used for assessment of treatment response following locoregional treatment. I'm going to focus on CT MRI LIRADS, and it is a standardized system for HCC diagnosis using CT and MRI. We have a CT MRI algorithm, and we provide standardized imaging features, which we'll discuss a little bit later. And LIRADS also provides standardized definitions not only for the imaging features, but anything that has to do with the diagnosis of HCC on CT MRI, including definitions of the phases, definitions of the technique, and so on. So this is a way to really standardize the process across various institutions and levels of expertise. CT MRI diagnostic LIRADS includes 8 diagnostic categories, and they range from definitely benign to definitely HCC, and this is LIRADS 1 through LIRADS 5. And we also have kind of side categories, including LRNC, non-categorizable, LRtiv, tumor in vein, and LRM, probably or definitely malignant, not necessarily HCC. And again, we will discuss this shortly in more detail. To assign the categories, we use 4 steps. So step number 1 is we apply the LIRADS algorithm. And again, this is the algorithm in a nutshell. And we start with looking at the kind of upper part. And the first thing is untreated observation without pathologic proof in patient at risk of HCC. And I want to highlight patient at risk for HCC. And this is a very important point to make because LIRADS is only applicable in patients who have risk factors for HCC. These include patients with cirrhosis, patients with chronic hepatitis B, even in absence of cirrhosis, and patients who have or had HCC, including patients who are either liver transplant recipient or candidates. It is important to remember that LIRADS is not applicable if patients do not have these risk factors. We also at this point do not use LIRADS in patients who are less than 18 years old. We also do not use LIRADS in patients who have cirrhosis related to vascular disorders. Why is it important? Why is this a requirement? Well, if you look at this particular lesion, it has arterial phase hyperenhancement, it has a washout appearance and a capsule appearance. In the general population, there is a differential diagnosis for this lesion, which includes HCC, hepatocellular adenoma, and hypervascular metastases. In the patient with risk factors for HCC, the pretest probability for HCC is high enough so that the specificity and positive predictive value for LIRADS 5 criteria is nearly 100%, which means that there's no differential diagnosis. And in the patient with appropriate risk factors, this particular lesion is almost 100% HCC. So once we are sure that we're dealing with an appropriate patient population, we can go down the decision tree. The first node in a decision tree, if the lesion cannot be categorized due to image degradation or omission, the category is LRNC, non-categorizable. Well, to understand what LRNC is, we have to kind of touch upon what are the required phases in LIRADS. And these are arterial phase, portal venous phase, and the delayed phase. And these are equally applicable to both MRI and CT. So again, you need arterial phase, portal venous phase, and delayed phase to appropriately categorize the lesions. And if, particularly if arterial phase is either missing or non-diagnostic, that it creates a problem. So LRNC is assigned if we have absence of one or more required phases, either because it was not obtained or because it is non-diagnostic. And as a result, we cannot say whether the lesion is more likely to be benign or more likely to be malignant. What do I mean by this? Well, here's an example of a patient with a small lesion on T2-weighted sequences, so it's a little bit hyperintense. And when we gave contrast, the patient was completely unable to hold their breath. So we know that there's a lesion, but if I ask you, do you think this is more likely to be hemangioma or more likely to be HCC? The answer is, I really don't know. I really can't tell. And this is an appropriate time when you would apply LRNC category. It's also important to remember LRNC should not be applied when the lesion just has very unusual appearance or you're really not sure which category it should fall in. Again, LRNC is really applicable only when we have technical issues. So the next node in the decision tree is LRtiv, which is definitely tumor in vein. And we apply this category when we see enhancing tissue in vein unequivocally. And in these cases, we may have a parenchymal mass. And we also have cases where there's really not a clear parenchymal mass. So presence or absence of parenchymal mass is not a requirement for LRtiv, but definite enhancing tissue in vein is a requirement. This is the definition for LRtiv. The next node in the decision tree, if definitely benign, we assign LR1. And at this point, LIRADS doesn't provide exact diagnostic criteria for these entities, although these entities and their imaging appearances, particularly in patients in cirrhosis, are discussed in the LIRADS manual. But we mostly rely on a radiologist's pre-existing knowledge to diagnose these conditions. And these include definitely benign things like cysts, hemangiomas, and so on and so forth. Here's an example of a well-defined T2 hyperintense, non-enhancing lesion, which is definitely a cyst. There is no question, 100%. There's absolutely no uncertainty in the diagnosis, and this is the appropriate application of LR1 category. Next, we'll come to LR2, which is if probably benign. And again, these are the same entities as we saw in LR1 list, but there may be something about them that you're still pretty sure that this is a benign entity, but there's something about it that kind of is not 100%. So if there's less than 100% certainty, LR2 category is the appropriate. And for a second, I'm going to kind of focus on this LR2 distinctive nodule because this is a specific entity which is only present in LR2 list. What are LR2 distinctive nodules? They're nodules. They have to be less than 20 millimeter in diameter. They should not have any major features or LRM features. And also they should not have ancillary features of malignancy. So when all of these three conditions exist, we can apply LR2 distinctive nodule as the category. So the next node in decision tree, if probably or definitely malignant, but not specific for HCC. And LIRADS provides several imaging features, so-called LRM imaging features, which help us diagnose this category. These are targetoid features, including rim arterial phase hyperenhancement, peripheral washout appearance, and delayed central enhancement. If any of these imaging features are present, LRM category is applied. We can also have targetoid appearance on diffusion-weighted imaging and on hepatobiliary phase images. And again, you can see this theme of concentric target-like appearance. It is a feature of non-HCC malignancy. Again, important to remember, you need only one LRM feature to categorize a lesion as LRM. And another important thing to remember is that LRM category does not exclude HCC. and a good proportion of HCCs, atypical HCCs, will fall into this category. So once we went through all these kind of decision nodes, and we excluded LRNC, LRtiv, LR1, LR2, and LRM, we are now left with a choice of LR3, 4, and 5, and we use CT MRI diagnostic table to categorize lesions 3, 4, and 5. Before we get to the CT MRI diagnostic table, however, we have to discuss the major features. What are major imaging features? We'll start with non-rim arterial phase hyperenhancement, which we define as enhancement in the arterial phase unequivocally greater than the background parenchyma and not most pronounced in the periphery of the observation. Compare that to the rim arterial phase hyperenhancement, where the hyperenhancement is primarily around the periphery. So these are the example of non-rim arterial phase hyperenhancement on various modalities with various contrast agents. And again, you can see that regardless of modality or contrast, the definition stays the same. It's very important to remember that non-rim arterial phase hyperenhancement is a requirement for LR5 category, which means that if you have a observation which does not have non-rim arterial phase hyperenhancement, no matter what, it cannot be categorized LIRADS 5. So it doesn't matter how fast it grows, what other imaging features it may have. This, without non-rim arterial phase hyperenhancement, LR5 category is not applied. Non-peripheral washout is our next major feature, and we define it as visual temporal reduction in enhancement from the earlier to the later phases. And as a result, there's hypoenhancement of the observation relative to the parenchyma. And again, this hypoenhancement is not primarily in the periphery of the observation. And again, contrast that to an example of peripheral washout, where this hypoenhancement is concentrated in the periphery. These are examples of non-peripheral washout on various modalities and various contrast agents. And a very important point to make here is that non-peripheral washout can only be assessed on the portal venous phase if we use Getaxetate enhanced MRI. Whereas with extracellular enhanced MRI and CT, we can use either portal venous phase or delayed phase. Enhancing capsule is our next major feature, and it's defined as smooth, uniform, sharp border, which is unequivocally thicker or more conspicuous than the fibrotic bands in the background parenchyma. Enhancing capsule can be assessed on either delayed phase or portal venous phase, and there's no restriction when it comes to Getaxetate enhanced MRI. Size is our next major feature, and we measure it as largest dimension from outer edge to outer edge of the observation. If the capsule is present, it should be included in the measurement. And again, it's very important to remember that size over 10 millimeters is a requirement for LIRADS 5 categorization. So if we have this observation which measures 9 millimeters, it cannot be categorized LIRADS 5. Again, regardless of what other features are present, size over 10 millimeters is absolutely required for LIRADS 5 category. Another thing to remember for size is that we should not use arterial phase or diffusion-weighted imaging to measure if the observation is visible in any other sequences or phases. So here's an example. We have arterial and portal venous phase images. We have an observation with non-rim arterial phase hyperenhancement and non-peripheral washout. If we use the arterial phase, the observation measures 12 millimeters, which will allow us LIRADS 5 category. If we use portal venous phase, the observation is only 7 millimeters, which would lead us to LIRADS 4 category. Which one is correct? Well, you have to remember that we should not use arterial phase images because you can have perilesional enhancement. On the diffusion-weighted sequences, we can have distortion, and as a result, the size can be overestimated. And as a conservative measure, we should always avoid using these two phases if possible. Threshold growth is defined as size increase of a mass by 50% or greater within 6 months. Remember, the definition of threshold growth was updated in LIRADS version 2018. Previously, there were 3 ways to get to threshold growth: either 50% size and greater size increase within 6 months, or greater than 100 size increase in greater than 6 months, or if there was a new lesion more than 10 millimeters in diameter within 24 months. So all these 3 kind of situations would allow us to give threshold growth to the observation. But remember, in LIRADS 2018, only the top one, only 50% of greater size increase within 6 months is considered threshold growth. Any other change in size is considered subthreshold growth, which is an ancillary feature of malignancy. So what is a general rule that we have to remember when talking about major features? If we're trying to figure out if the major feature is present or absent, the general rule is categorize this feature as absent. So again, if you're trying to figure out is there arterial phase hyperenhancement or not, you should characterize it as no arterial phase hyperenhancement. Another thing to remember is as each and every one of the major features by itself does not yield 100% positive predictor value for HCC. So we can illustrate it by creating a graph where on the y-axis we have increasing positive predictor value for malignancy, and on the x-axis we have increasing positive predictor value for hepatocellular origin. And each individual major feature is going to fall somewhere within this graph, depending on how specific it is for malignancy in general and for HCC in specific. For LIRADS 5, we want the positive predictor value for malignancy and for HCC to be both as close to 100% as possible. And notice that none of the major features by themselves allow us to do that. However, we can view the major features as building blocks. What does that mean? The different combinations of major features will yield different probabilities of HCC. So if we look at our 5 major features, a combination of arterial phase hyperenhancement and washout and an observation that's over 20 millimeters in size gives us 100% probability of HCC. And that is, again, in the patient who's at risk for cirrhosis, for HCC. A combination of arterial phase hyperenhancement, washout appearance, and enhancing capsule in the observation that is less than 10 millimeters in size has about 70% probability of being HCC. And arterial phase hyperenhancement in observation 10 to 19 millimeter in size has approximately 30% probability of being HCC. In 2018, we do not report probabilities yet, but we do talk about the categories. And again, each of the category reflects a different probability of HCC. So again, different combination of imaging features yield different probabilities of HCC, and these probabilities are reflected by the LIRADS categories. So now that we went through this, we can figure out how we can get together and figure out these combinations and what the probabilities and categories should be. And this is where we use the diagnostic table. Let's take a look how we're going to apply it. This is the observation and arterial phase and portal venous phase images. The first thing we look at is whether or not there's arterial phase hyperenhancement. In this lesion, we clearly have arterial phase hyperenhancement, and therefore we select the right-hand side part of the table. The next thing we look at is observation size, and in this case, it's a 43 millimeter observation, which allows us to select the far right column of the table. And then we count each additional major feature, and in this case, we have a capsule and washout appearance, which means we have 2 additional major features, which means we select the bottom row, and then intersection of the selected row and column is what gives us the final category of LIRADS 5. Let's take a look at another case. Again, arterial phase and portal venous phase images on MRI. The first thing we're going to look at is whether or not there's arterial phase hyperenhancement. On this image, it kind of looks like there's no hyperenhancement, but we can confirm that with subtraction. So we can confirm that there is no arterial phase hypoenhancement, which means we're going to select the left side of the table. The next thing we're going to do is look at the observation size, and in this case, this is a 27 millimeter observation, which means we're going to select the second column from our left. The next thing is we're going to do is we're going to count additional major imaging features, and in this case, we only have the washout appearance, and that means we're going to select the middle row. And again, intersection of the selected row and a column is what gives us the final category, which is LIRADS 4 in this case. So this kind of long discussion was all about the first step in LIRADS application of the algorithm. The next step is optional. We can apply ancillary features to kind of nuance the final category. And if we're going to do it, we're going to do it following several rules. And these rules are, if we have one or greater ancillary feature favoring malignancy, we can upgrade by one category only, with a caveat that we cannot use ancillary features to go from LIRADS 4 to LIRADS 5 category. So we can upgrade by one category up to LR4. If we have one or more ancillary features favoring benignity, we can downgrade by one category. And it's important to remember that absence of ancillary feature of malignancy should not be used to downgrade, as absence of ancillary features of benignity should not be used to upgrade the category. And if we have both ancillary features favoring malignancy and favoring benignity, we do not adjust the category, we just leave it as is. Step number 3, if needed, we can apply the tie-breaking rules. What does that mean? Well, if after going through the algorithm application and going through ancillary feature application, you're still not sure if it's LIRADS 3 or LIRADS 4, you follow these tie-breaking rules. And the tie-breaking rules kind of tell you that we should select the category which reflects lowest certainty, either lowest certainty of malignancy or lowest certainty of hepatocellular origin. Which means that if you're looking at LIRADS 5 or LIRADS M, the tie-breaking rule tells you that you should choose LRM category because it reflects lowest certainty of hepatocellular origin. Similarly, if you're debating between LIRADS 2 and LIRADS 3 categories, the rule is you should use LIRADS 3 because it creates a lower certainty of benignity. And the final step, step number 4, is a final check. You arrive at the category, you just decide, does this seem reasonable? Does this observation fit into the category that you arrived? If yes, you're done. And if no, you should reevaluate the imaging features, reevaluate the prior studies, and try to figure out where the mistake may have been and assign the category which may be more appropriate. So just a few more seconds, I just want to talk about LIRADS version 2018 release. LIRADS was developed and refined over many years. The first version was released in 2011, and then there were 3 subsequent releases since then, each one kind of improving improvement in the algorithm and atlas and kind of definitions. And in 2018, the version came out because it allowed us to have unification of LIRADS with ASLD, American Association for Study of Liver Diseases, which is the major governing body of hepatology. And this was an important step because now the LIRADS is implemented, accepted, and included in the ASLD 2018 HCC practice guidance. So if you look at this seminal paper, you'll see that the kind of approach to surveillance and diagnosis of HCC follows the suggested algorithm proposed by LIRADS. You can see that it uses LIRADS categories, and you can see that the table uses LIRADS 5 criteria. So that means that there is no more separate ASLD HCC diagnosis. ASLD fully embraced and accepted LIRADS 5 criteria, or LIRADS criteria, period. In order to have this integration, we had to change LIRADS 5 criteria and therefore release LIRADS 2018. So what is this change to LIRADS 5 criteria? Well, if we have an observation which is 10 to 19 millimeters in size, has non-rim arterial phase hyperenhancement and non-peripheral washout, in LIRADS 2017, visibility on antecedent surveillance ultrasound was required for categorization of LR5 ultrasound. All other observations would fall under LIRADS 4 category. In 2018, the requirement for ultrasound visibility was removed, and therefore all 10 to 19 millimeters with arterial phase hyperenhancement and non-peripheral washout are categorized LIRADS 5. We also simplified the threshold growth definition, which is now fully aligned with Optin criteria. And as a result, the observations 10 to 19 millimeters with non-rim arterial phase hyperenhancement and 50% or greater size increase within 6 months previously had to be categorized LR5G, but now we can drop the G designation and just categorize them as LIRADS 5. So to summarize, HCC diagnosis is complex because we need to detect the lesion, we need to distinguish it from other lesions and pseudolesions and cirrhosis, and we need to make a definitive diagnosis by imaging, which means that we need near 100% specificity to do so. CT-MRI LIRADS is a standardized system for HCC diagnosis. We have 8 diagnostic categories, which reflect probability of benignity, malignancy, or HCC. And we use major features as building blocks to arrive at the category which then reflects the probability of HCC. Release of version 2018 allowed for integration of LIRADS into ASLD HCC guidance, which is a huge step. So that means that more and more hepatologists will request LIRADS, and so LIRADS will become more mainstream. But changes to LIRADS 5 criteria will need to be validated in future prospective studies. With that, I thank you very much for your attention.